Welcome to the Stroke Circle, Primary and Secondary Stroke Prevention, Breaking New Ground in Antithrombotic Management. I'm Greg Albers from the Stanford Stroke Center, and together with my colleagues up on the podium, we're going to try to put a few things in perspective that you may have heard over the last couple of days and bring you some new and exciting information that's been published over the last year, particularly in regards to atrial fibrillation. It's been a big year for clinical trials in atrial fibrillation, so we decided to highlight AFib for two of the three talks. We've got disclosures from all the faculty, which are in your handout as well as up on this slide. And we also have disclosures of anybody who's been involved in this program in any form to meet CME requirements. I'm sure everyone is familiar with Dr. Chris Diener, who's been involved in a tremendous number of both acute stroke as well as stroke prevention trials. He's particularly had a great interest and played an active role in atrial fibrillation stroke prevention trials over the last decade, and he is going to talk about whether we are on the cusp of a new world. Chris.
Good evening, ladies and gentlemen. Though this is what I will talk about, how can we evaluate the risk of stroke in someone who has atrial fibrillation? Then I will shortly discuss the guidelines for primary and secondary stroke prevention in people with atrial fibrillation. And the main part of my talk will concentrate on new compounds and new therapies for stroke prevention in atrial fibrillation. Now let me start with the case. This is a 60-year-old man, suffers from hypertension and diabetes. He is overweight. And like Churchill, he doesn't exercise. He suffered a transient ischemic attack 6 months ago and was put on aspirin for secondary prevention. Now today he is admitted with a moderate left MCA territory stroke. Ultrasound doesn't show any significant stenosis or occlusion of brain supplying vessels, but the 24-hour Holter monitoring shows atrial fibrillation, and the MRI shows mild small vessel disease. Now, how would you do secondary prevention in this person? And these are the options you have for voting. Warfarin with an INR 2 to 3, or warfarin with an INR between 3 and 4.5, aspirin 75, aspirin 325, low-dose warfarin, warfarin light, together with aspirin, or warfarin at a standard dose together with aspirin, or the combination of clopidogrel and aspirin. Now I would like to ask you to vote. Okay, almost everyone would go for oral anticoagulation INR 2 to 3. But let me quickly mention a few things where I won't show you the results of clinical trials because they were done a long time ago. Number one, low-dose warfarin together with aspirin is not as effective as warfarin INR 2 to 3. And INR 2 to 3 of warfarin, in addition, giving aspirin only increases the bleeding rate, but not the efficacy. And now there is one way how we can evaluate the risk of someone to have a stroke in a person who has atrial fibrillation. And what you usually should use is a so-called CHETS-2 score. Now the CHETS-2 score is highly predictive of stroke, but as you can see here, in people who already had a stroke, it's also highly predictive of mortality. So the higher the CHETS score, the higher is the mortality of this person. And this is based, as you can see, on 100,000 people who had a TIA stroke and had atrial fibrillation. Now, what did we know before we started with the new trials on anticoagulation? This is a meta-analysis of 12 randomized controlled trials in atrial fibrillation. And these were all done in primary prevention. So people had AF, but not yet had a TIA or a stroke. And the blue lines is placebo, and so you see the stroke rate per year is between 4 and 7%. And then the gray bars is aspirin, and you can see that aspirin was only used in 2 of the trials. In one trial, there was no difference to placebo, and the other one, the relative risk reduction was 42%. And the orange bars is warfarin. And on average, warfarin reduces stroke risk by about 70%. In addition, this is the most cost-effective preventive therapy for stroke. And the reason is that warfarin is extremely cheap. It's not an expensive drug. So there is no doubt that warfarin is effective, and the relative risk reduction compared with aspirin is 40%. Now, this is the only trial that was done in secondary stroke prevention, the European atrial fibrillation trial. It recruited about 1,000 patients and randomized them to placebo, to aspirin 300 milligrams per day, or to oral anticoagulation. The INR in this trial was between 2.5 and 4. And with aspirin, there was a 14% relative risk reduction compared to placebo, which was statistically not significant. And with warfarin, the relative risk reduction was 66%. So all the evidence we had until now was based on one trial. This trial was not replicated. But it clearly showed that warfarin is effective in secondary stroke prevention. Now, what do the guidelines say? Well, on the left side are the guidelines from the American Heart Association, on the right side from the European Stroke Organization. And what they use is a JETS-2 score, or they look whether people have a certain age, and the age limit is usually 75 years or 65 years, and then whether people have additional risk factors. So someone who has what's called lone atrial fibrillation, no risk factors, would either be not treated or receive low dose of aspirin. If people have one risk factor, or they are aged between 65 and 75, there is a choice between aspirin and warfarin. But people who are above 75 and have several risk factors definitely need anticoagulation with warfarin. Now, these are the guidelines for secondary stroke prevention. So if someone has AF and had an ischemic stroke or TIA, this person should receive adjusted dose warfarin with an INR between 2 and 3. And as you can see, this is class 1, level of evidence A. And in people who are unable to take oral anticoagulation, the recommended dose of aspirin is 325 in the United States and 300 milligram in Europe, because 325 is not available in Europe. We only have 300 milligrams. Now, what are the new therapies we have for the prevention of atrial fibrillation? Number one, why do we need new therapies? Well, the problem with warfarin is the need to monitor the coagulation system, and this is a nuisance for patients. In addition, warfarin has a very narrow therapeutic index. If the INR is below 2, you have an increase in ischemic strokes, as you can see on the image on the left side. And if the INR is above 4.5, you have a steep increase in the risk of cerebral bleeds. In addition, warfarin has lots of interaction, both with food and with other drugs, and this explains why the monitoring has to be done in short time intervals. There are other limitations. So one is a delayed onset and offset, so it takes about a week until warfarin really works, and it's very slow in reversibility. And one thing which has to do with marketing and imaging, unfortunately, many patients are aware that warfarin is rat poison. That's the purpose why it was developed.